Welcome everybody, good evening and thank you very much for joining us. My name's Maxine and I'm one of the private patient services advisors here at the McIndoe Centre in East Grinstead. The McIndoe Centre, which is part of the wider Halder Health Group, has a fabulously rich history dating back to World War II and is named after the famous Sir Albert McIndoe. The McIndoe Centre is a hub of excellence in both cosmetic and reconstructive surgery and home to a number of expert consultants. One of those experts is our speaker this evening, Miss Alex Molina, and we're hugely proud to have her working with us here at the McIndoe. Alex is a consultant plastic and reconstructive surgeon who will be talking to you about breast reduction and breast uplift surgery. Alex has been awarded a fellowship at the Royal College of Surgeons and is a clinical lead at the world-renowned Queen Victoria Hospital. She'll be running through her presentation, followed by a Q&A session. Before that, though, I do need to run through a few bits of admin with you. We are recording the session today. Therefore, to protect your identity, we have invited you to invent a pseudonym for yourself, if you so wish. Just so you know, even then, we will not be sharing your name. Your camera and mic have been muted. I do hope this is okay. You're welcome to ask any questions via the chat function. This is dependent on the device you are using. If you're not able to do this, please raise your hand at the end of this session. This session is for you after all. So without any further ado, I'd now like to hand you over to Alex, Miss Alex Molina. Alex, welcome.
Thank you. So welcome everybody and thank you for joining. As Maxine said, my name's Alexandra Molina, or Alex. I'm one of the consultant plastic surgeons at the Queen Victoria Hospital. I've been a consultant there for 4 years. Prior to that, was briefly a locum consultant at the Royal Marsden. And I'm the breast lead consultant now for Queen Victoria Hospital. I've more recently started in cosmetic surgery. One of the operations I'm most enthusiastic about is what I'm going to talk to you about this evening. So if I could have the next slide, please. So we're going to be talking about two closely linked operations, breast reduction and breast lift, which is called mastopexy. This is just a brief run through of what we're going to talk about. So firstly, why might women want to have a breast reduction? Then what's the difference between breast reduction and a lift or mastopexy? One of the commonest questions I get asked is what scars will I have? And also every pregnant patient these days will ask about the risks of surgery. Then it's useful to know a few practicalities. So what happens before surgery, what exactly happens during the surgery. We won't go into too much detail on that, don't worry. And then what does the recovery entail? And then at the end, I'd like to share with you a few photographs of recent patients I've operated on. Again, not too gory, so hopefully won't put anybody off. If I could have the next slide, please. So it may sound fairly obvious. The reason patients seek to have a breast reduction is to reduce the size of large and heavy breasts. And usually patients have a range of symptoms from their large breasts. Sometimes back pain, neck pain. A common complaint is the straps of bras digging in. And they struggle to find clothes, particularly if their breasts are out of proportion to the rest of their frame. Some women with really large and droopy breasts will get rashes in the creases under their breasts, which is particularly unpleasant and particularly happens in the summer months when it's warmer. And then some women don't like the unwanted attention and really suffer psychologically as a result of having large breasts. So there's a variety of reasons, and not all of these will apply to every woman. If I could have the next slide, please. So what's different about a mastopexy or lift? So some ladies want their breasts to be smaller, and other ladies, especially after pregnancies, perhaps after breastfeeding, have more deflated breasts and they don't want to lose volume. So what a lift does is improves the shape of the breasts, but doesn't remove a significant amount of breast tissue. And the reason it's most commonly done is to correct ptosis, which is the medical name for droopiness of the breast. And we mainly do that by removing excess skin, but not volume. So you get a breast afterwards that appears more full. There are various grades of ptosis or droopiness, as you can see in the picture. So ideally we want the nipple to sit above the level of the crease under the breast. Quite common to get grade 1 or 2 ptosis, which is where the nipple moves to the level of the crease under the breast, or with grade 2 it moves to below the crease of the breast. I think where women get more upset by the shape of their breasts is when they're approaching grade 3 ptosis, which is where the scenario in the picture on the right hand side, where the nipples are pointing at the floor, and those sorts of ladies will really benefit most from a lift. If I could have the next slide, please. So scars can be the same with a lift as with a breast reduction. Nearly all the breast reductions require an anchor-shaped scar, which is the picture on the right. So the scar goes around the areola, which is the coloured part around the nipple, and then vertically downwards, and in the crease under the breast. Now, although that sounds like a lot of scarring, in practice, 2 of those areas usually heal very well and quite inconspicuously. So the scar around the areola is at the junction of the coloured skin and the paler skin. So that usually becomes quite concealed. The scar under the breast is quite concealed by the breast tissue above it. So it's really that vertical scar that is usually most obvious, but it does, as with all scars, fade with time. With a lift, if it's only a minor lift, so we're not talking about the most severe grades of ptosis that we discussed on the last slide, but with a minor lift, it may be possible to do this just with a scar around the nipple, such as the picture on the left. And then there's a sort of in-between option, which is the vertical scar lift. But usually, as I say, that does already give ladies the most obvious scar. And in my hands, I think I tend to either use the pattern on the left or the pattern on the right in most cases, but it's obviously tailored to the individual patient and what they wish to get out of the operation. Next slide, please. So what are the risks? So with any surgery, there's always scars, which we've discussed. There's always a risk of infection of the wound. Most often infection is quite mild and may just require a course of oral antibiotics. Occasionally it can be a more severe infection and in rare cases require readmitting to hospital, but that's really quite unusual with this sort of operation. Bleeding is a risk, and particularly with the larger breast reductions, particularly when we're really removing a lot of tissue and the breast tissue is quite dense, which is usually the case in younger women. We do use drains in larger breast reductions, which are little tubes to drain any excess blood, which usually come out the next day. Wound healing problems. So with that anchor-shaped scar that we described, at the T-junction, it's really an upside-down T between the vertical scar and the scar in the crease under the breast. Because you've got sort of 3 scars meeting there, you can get a little bit of delayed wound healing at that area, and it can take a little bit longer to heal. But usually we'd expect the wounds to be healed within 2 weeks. You can get what's called fat necrosis, and that's hardening of the fat, and that's basically because we're lifting the breast and cinching it all together, and some of the fat cells can effectively die and harden, but usually that's fairly minor and will just settle with some massage. We advise patients to massage the scars anyway, and at the same time we'd say to massage any firmer areas. So asymmetry we always warn patients about. So some patients start off asymmetrical, and actually we can often correct that, and one of my examples will hopefully show that later. But it's normal to have a degree of asymmetry, and we always tell patients that although we'll do our very best to make things as symmetrical as possible, there may be subtle differences, for example in the diameter of the areola in the volume of the breast. There may be subtle differences. Inability to breastfeed. So after a breast reduction, we do tell women that they're unlikely to be able to breastfeed, and that obviously applies to the younger group of women who may not have completed their family yet. There is a theoretical risk of loss of the nipple. That is very rare. It's most common when the breasts are very, very droopy and the nipple has to move a very long way up. So that is pretty unusual. What's much more common is a change in feeling or sensation, especially to the nipple, but also to the skin of the breast around the scars. Next slide, please. So what happens before surgery? There's obviously quite a bit to talk about, and it's important to meet your surgeon for at least 2 consultations before surgery. And after the second consultation, you'll have a cooling off period, as it's called, of at least 2 weeks before you come in for your surgery, but often longer. You should be asked what you don't like about your breasts and what you're hoping to achieve. You'll ask lots of general questions about your medical history, your medications, and so on. You'll also be asked about smoking. So it's a really good idea if you're a smoker to stop smoking before this surgery, because it helps an awful lot with the healing. And over a certain age, we'll discuss with you potentially having a mammogram before the surgery, just to make sure, obviously, that there's no signs of any precancerous or cancerous change in the breast. You will discuss what cup size you'd like to be. We never guarantee a particular cup size because, as most women probably know, you go into different shops and you get a completely different size from different brands and different manufacturers. We also send you off bar shopping before surgery to get some supportive non-wired post-surgical bras. Next slide, please. So what happens on the day of surgery? So you will meet the anaesthetist. It's very important. He will be keeping you asleep for about 3 hours while we do our work to lift and potentially reduce your breasts. You then wake up potentially with drains. As we said, for the larger breast reductions, we may leave a little tube on each side just to drain any excess blood. You will probably feel uncomfortable. You'll know that something's happened, but not in pain, because I'm usually very careful to put lots of local anaesthetic in whilst you're asleep. And given the amount of scarring, actually, this operation is not usually as painful as one might expect. It's most common that patients will spend 1 night in hospital after the procedure. A more minor lift might be done as a day case, but most of the breast reduction patients, I would say, to stay in 1 night. And you usually be able to go home the next day after a checkup and removal of drains if you have drains. Next slide, please. So what's recovery like? Often get asked about this. So it is obviously a fairly big surgery, but the recovery is pretty quick. So we get you back in about 1 week for a dressing clinic appointment with the nursing team. Most patients are able to go back to driving and light work at around 2 weeks. More physical activities, you have to be a little bit more careful, in particular gym work and lifting heavy things which could put strain on the scars. So we'd say to avoid those for between 4 and 6 weeks, depending on the extent of your procedure. So in terms of dressings, are quite minimal and quite user-friendly. So we simply use this brown micropore tape, which is like an adhesive paper tape over the scars. Usually I like to use some skin glue underneath, so the wounds are stitched all with dissolving stitches, and they're all under the skin, so there's no stitches to see on the outside. Just a little coating of glue and then the brown tape, and that is great because it allows you to shower, so you can go in the shower and then simply pat it dry, or use a hairdryer on a cool setting afterwards. We actually now advise women often to tape if they can for 6 weeks. It used to just be for a week or 2, but we found that the quality of scars is actually improved if women are happy to carry on taping for 6 weeks. And most women are able to just change the tape once a week at home themselves, so it doesn't mean that you have to come back and forth for dressings. Then after 6 weeks, bid goodbye to the brown tape, bid goodbye to the post-surgical bra, and start massaging the scars. And I usually say start with something water-based like E45 or similar before moving on to the bio oil and that sort of thing. Next slide, please. So just moving on to a couple of examples. So the first lady I wanted to show you is a young 22-year-old who's a student teacher. And she came to see me complaining of back pain and her bra straps really digging in and weighing her down. She was hoping to become a teacher and she really disliked her breasts. We measured the nipples from around the collarbone area and her nipples were down at 32 centimetres, and as you can see they've been lifted quite a bit, but she has also had a significant breast reduction. She's had 700 grams, so about 1.5 pounds of tissue removed from each side. And so the picture is only 10 days post-operative, so she is still quite swollen, and we would expect her breast to drop and have a slightly more natural shape in future, but obviously she's quite pleased. And the nice thing about this operation is that it's quite rare to have an unhappy patient. Most of my patients are really, really happy after this operation and literally feel like a weight has been lifted in the case of the breast reductions. I think we see more pictures of this lady on the next slide. Yeah, so you can really see from the side how the shape of her breast has improved. So yeah, she's delighted. Next example, if we go on to the next slide, is a slightly older lady. We can go through the ages. So she was 40 years old and she had the grade 3 ptosis or drooping that we're talking about. So her nipples were right at the bottom of her breast, sort of pointing towards the floor. And she had breastfed twins and was obviously really dissatisfied with the appearance of her breasts, but she was also suffering from a lot of nasty rashes and fungal infections under the folds of her breasts, and she'd been under the dermatologist for this. She also complained of back and neck pain. So she had again a breast reduction, removing 600 grams of tissue from the right. So you can see she was a bit bigger on the right hand side. That's when you look at the picture, that's the left breast that you're looking at on the left hand side of the screen. That's actually her right breast, was a bit bigger. So we removed 600 grams from that side, 500 grams from the left side. You see now she's pretty symmetrical. Again, quite early photos. Her scars are quite pink, and we'd expect those to continue to fade over the next 6 to 12 months. We've got one more example to show you. So this patient's a bit different. So if you look at the photo on the left, which is her before picture, she's actually a breast reconstruction patient. So that's a lot of the work that I do in the NHS. So on the right hand side, this lady who's 57, who's a ceramicist, I think, she developed a right breast cancer, had to have a mastectomy, and she had an implant reconstruction. So that rather deformed looking right breast that she's got in the before picture is actually an implant, and she had very thin skin. The implant was placed just below the skin after her mastectomy, and this was uncomfortable, pulling on the skin, and she was obviously really unhappy with the appearance. So what we did reconstructively was to replace, she was very, very thin, especially in her bottom half, so we had to use the tissue from 2 of her upper thighs to replace the implant on that right side, and we also removed some of the excess skin where the implant had stretched it, and she's now going to go on to have a nipple reconstruction on that side. But I just wanted to show you an example of a lift where we haven't actually removed any tissue. So on the left side, which again is the right side as you're looking at the screen, we've done what's called auto augmentation. So breast augmentation is classically using implants, but for her we've done a breast reduction type scar. So she's actually got the anchor shaped scar that we talked about, going round the nipple, vertically down and underneath, although obviously you can't see the underneath scar in her. But instead of discarding the tissue in the lower part of the breast that we'd normally remove in a breast reduction, she quite liked the size of her left breast, and it looked appropriate for her frame. So instead of discarding the tissue, we kept it and tucked it behind the rest of the tissue to act almost like an implant to achieve an uplift and a much more youthful breast shape. So again, she's very pleased with the results. Next slide, please. So I think that comes to the end of the presentation. And now I'd be delighted to take some questions.
Okay, thank you so much. Thank you so much, Alex. That was really insightful, really interesting. I learned quite a lot there. So yes, we do have some questions that people did submit before the presentation. I know you touched on people needing a mammogram after a certain age. There's a lady who submitted the question and said she's 60 years old. Can you be too old to have a breast reduction at all?
So I think that's really individualised to the patient. There is no age cut-off for having breast reduction. One of the happiest patients I've ever done this surgery on was a 70-year-old lady, and she said she really wished, her only regret was that she didn't have it done sooner. So certainly we do see ladies in their 60s that have this surgery. Obviously it goes without saying you have to be fit enough to have an anaesthetic, so we wouldn't recommend it for older ladies who've got lots of medical problems and that would cause a problem with that. But as long as they are relatively fit and understand the risks of the surgery, there's not really any more risk for a 60-year-old having it who's fit and well than a 40-year-old, and we'd absolutely support that. So regarding the mammogram, obviously the age of 60, hopefully the patient would be in the national screening programme anyway, so they would have already had a mammogram.
Okay, excellent. And you touched on the lady we saw earlier, the 22-year-old who had a breast reduction, which I can imagine was quite impacted on her mental health quite a bit. I was just wondering, going the other way, is there a limit to a person that you would operate on age-wise? Is 22 the lowest, or?
Yeah, so certainly I wouldn't do this operation on under 18s personally, and with the younger patients they have to understand a few things. So they have to understand that if they go on to have a family, their breasts might grow again, and certainly they might lose the nice shape that we create with pregnancies. They have to, as we discussed, understand that they wouldn't be able to breastfeed. So it's a bit more of a careful conversation with ladies who haven't completed their family yet. But some of them, like that 22-year-old, are so troubled by the symptoms, and if they're fairly adamant that they're not going to have a family within the next 5-6 years, then it seems justifying to do the surgery so that, you know, for potentially some of the best years of their life, they can get the benefit out of feeling comfortable about their breasts. So it's all about weighing up the risks and benefits for the individual patient.
Excellent. Thank you for that. We've had a question that's come through on the chat. I'll just read that out for you. Well done, Alex, for your work to make women look and feel normal. I cannot stress how key it is to be fitting in. I'm looking to get a breast uplift soon. What is the procedure at McIndoe and pricing?
Okay, so the first step, if you're interested in getting a breast lift, would be to contact Maxine and her colleagues via the helpline, and you can request a particular surgeon, or they will suggest somebody for you who's got expertise in this area, and then you come for a consultation. Prices for initial consultations vary, usually around between £150 to £250, and those will cover usually both of your pre-operative appointments. So we talked about meeting a surgeon twice. So you'd come and see them initially, you'd be examined, have a discussion about the surgery, and then you would get a formal quote from the surgeon as to how much the surgery would cost. And then if you're happy to go ahead following that quote, you would then meet the surgeon for a second operation, sign all the consent forms, go through all the risks in more details, and be booked in for a date for surgery. That's in a nutshell. What have I missed, Maxine? I'm sure.
No, I'm just thinking it's really important that people think about such a huge surgery, and as you said earlier, there's a 2-week cooling off period, isn't there, after the last consultation? So
yeah,
I think it's really important that we stress that as well. Thank you for that question. So another question that we had submitted before the webinar, a lady whose breasts are not overly big, but they are heavy. Would she be a suitable candidate?
Yeah, so she sounds like somebody who would benefit from a full assessment and examination in clinic. But yes, often I do hear a lot about heavy breasts, and particularly, like we said, weighing down and causing neck and back pain, and straps digging in. So yes, sometimes people literally just want to feel lighter. Usually for a breast reduction, there is some kind of drooping that we'd want to correct as well at the same time. But yes, it varies. What one patient thinks is a large breast may not be a large breast to another patient, and it's all about trying to achieve what the particular patient wants. And as long as you and your surgeon can agree about where you're trying to get to, then I think we can help most patients.
Okay. Going back to that, once a patient has had a breast reduction, and it has been impacting on their physical kind of standing with back pain and hip pain and things like that, will there be an immediate relief of that?
So that varies completely from patient to patient. I've had some patients who said, oh, literally from the day after, I stood taller, everybody told me my posture was better, and the pain disappeared. We do warn patients, especially regarding the back pain and neck pain, that there's no guarantee that will disappear, because sometimes patients who've had poor posture and been weighed down by heavy breasts for many years will actually have some damage to the neck or to the vertebrae in the back, and therefore it may not be completely reversible. So we do say, hopefully this will help, but we can't 100% guarantee that.
Of course. Okay, thank you. You did touch on in your presentation having an uplift without implants. Most a lady here has asked, most uplifts do seem to include implants. Are you able to have one without implants?
Absolutely, and I think implants are a big commitment, both financially because they don't last forever, but also thinking about the age you have them, and if you need to have them replaced 15 years later, there's no set time. Again, that varies, but for most women, implants won't last them their whole lifetime, and obviously having another general anaesthetic operation is quite a big thing to think about. So I think a lot of women don't realise that they do actually have a reasonable volume of breast tissue. It's just sitting in the wrong place. So if you can actually do like that last lady who had the reconstruction on the other side, if you can just sort of relocate all their breast tissue to where they want it to be, a little bit higher, a little bit perter, then they're often surprised by what a nice breast shape they can have, and it can almost look like an implant look without having to have an implant. And I think that's the best of both worlds. It reduces the cost of surgery slightly because you don't have to pay for implants, and it certainly reduces the cost and hassle in the long term by avoiding implants.
Excellent, thank you, Alex. Is there anything people can do? I know you suggested stopping smoking. I'm assuming that's to do with the surgery, the anaesthetic, or has an impact. What about diet? Is it good to change your diet beforehand? And obviously,
so that's a really good question. So yeah, stopping smoking helps both with the anaesthetic and the recovery and not getting chest infections after the surgery, and it also helps with the wound healing. So I'm pretty adamant that patients need to stop smoking before this type of surgery. So another conversation I like to have with ladies at the first consultation is about how their weight is and where they would like their weight to be. So I think it's better to actually do the surgery when someone's at what I call their happy weight. And it has to be something realistic. So there's no point in crash dieting and having the surgery and then putting on weight, because that will change the effects of the surgery. But I say it's nice to be at a stable weight that you're content with, that you think you can maintain. Yeah, not forever. Nobody can promise that, but you know, for the next few years, and that allows me to judge better how things should look, and allows me to give the patient the best result for the medium to long term.
Excellent, thank you. Is there anything that you're excited about that's coming up in the industry that you're looking forward to? Is there anything you're involved in that you can share with us without revealing too much, maybe?
Yeah, it's funny with implant technology, things are changing quite a bit, but with breast reduction and uplift, we've sort of been doing the same thing for a little while. There are various meshes that you can use to try to support the shape of the breast, but again, I find that actually using the patient's own tissue as a sort of mesh means that you're not paying for the expensive artificial material, and you're avoiding inserting artificial material into the patient, which is always a good thing in terms of infection risk and so on. So there is a sort of slight trend towards those things, but I think in general most plastic surgeons haven't taken that up for breast reduction and uplift. So I'd say most of the new technological things are around breast implants for augmentation at the moment, which are getting lighter and getting stronger, so they're less likely to rupture. And another reason to avoid implants is that there's been a rare, very rare lymphoma linked to breast implants, but that's largely the risk of that is now infinitesimally small, because they've altered the process by which they make the implants, so that's very rare. So I'd say, yeah, in different areas that I work in, there's lots of technological advances, but probably not for breast reduction. Okay,
brilliant, thank you. We've actually had another question come in on the chat. Do you think it's recommended to have multiple procedures at the same time? For example, breast uplift and facelift, just trying to rationalise.
Okay, so there are some operations that go well together and some that don't. There's no reason why you couldn't have a facelift at the same time as breast reduction, because obviously the face is in a completely separate area, the scars won't be pulling on each other, but the only thing to consider is how long it will take, and the costs involved in the recovery, really. So that's a conversation to have in detail with your surgeon, who may confer with the anaesthetist. I think people who are younger and fit and well can usually tolerate a longer anaesthetic than those who are perhaps a little bit older with a few medical problems. So again, it's a bit of an individual decision, but you can certainly combine breast reduction with other procedures. It's often done, for example, in combination with a tummy tuck, which is what a lot of women are seeking at the same time.
Okay, is that don't know if this is okay to say, I'm going to say it anyway, a mummy surgery?
A mummy makeover.
Mummy makeover, that's it. So yeah, that involves all different or multiple procedures, doesn't it?
Yes, it is. I have to say, I think that term must have been coined by a man, but yeah, that is what it's called. Okay, brilliant. Thank you so much, Alex. Well, I think that's all the questions we have for now. So I'd like to thank you, Alex, and thank you for all your questions, everyone. I hope it's given you a better understanding of what's involved in breast reduction and the uplift procedures. And also thank you to the wonderful team
the marketing team and everyone over here at the McIndoe for helping to put this all together. We'd love to know what you thought, so we'll be in touch with you soon. We'll share a link to this video, which will also be posted on our website. But in the meantime, if you have any questions whatsoever, please don't hesitate to get in contact with us. You can either email info.mcindoe@horder.co.uk or call us on 01342 488 Again, thank you so much for joining us. It's been very informative, very insightful. I'm repeating myself, but it really is, to be educated in these procedures. Thank you so much and have a good rest of your evening.
Thank you very much, Maxine. It was a pleasure.
Thank you.